Here's a, I don't know if anyone's seen this, Decision Aid. It's available online for free. But it's a big book, but it's very literacy tailored, so that literacy sensitive. So it's easy to read, lots of pictures, and you can see here. So this is just one example of one page that says, will my treatment choice affect my chances of living for 5 years? And it's evidence-based. It even gives like a ratings, quality of the ratings on out of 4 stars. This is 3 out of 4 stars. It says transplant from a living donor may, and careful with terminology, transplant from a living donor may be better than other treatment options. And it goes through and it shows these pictures, with the more boxes there are out of 100, the more, the better. So this is transplant from a living donor. You can see at 5 years, there's more boxes. And then with a deceased donor, a little less. And then PD and hemo are about the same. So it just goes through all of that for patients. So they can, early on in the book, they identify what things matter to them, and then they can go to those pages and say, oh, okay, this is what's important to me. It looks like this modality might be the best for me. But it's guided by this case manager who teaches the class, so it's not like they're doing it all on their own. In early versions of this project, it was just going to be a project about this decision aid. And it's amazing how it has grown based on patient feedback into this comprehensive program, because all the patients actually said was, the book is great, the class is great, but I really need someone to help me work through this. So this is my favorite project that I'm working on, honestly, because it has so much patient feedback and it makes it feel so relevant and helpful. We have a values tool that was modified after something developed by the Medical Education Institute. And it goes through, it's a survey that is included in the dialysis education class. And it goes through different categories of, values. So your lifestyle, your feelings, your body, thinking, and it asks you questions about how important each of those things is in terms of a treatment choice. So here's just an example of the summary page. At the top, if they've made a choice, it would be at the top. So this patient's, and this is displayed in the electronic health record too for the providers to see once a patient has filled it out. So the patient's current kidney failure treatment is CKD, patient preferred modality, non-dialysis, conservative care. So they already made a choice. If they didn't, it wouldn't be there, but they would just have these ranked values. And so it tells you what they said was extremely important, very important, important, somewhat, and then not important. So for this person, the most important, and this is, I think, a test patient, the most important things were doing my usual activities, how much my family and friends need to help. They don't want to be a burden, and living as long as they can. So you can use this, and I actually have used this as a provider. When I've had a patient who goes to the class and they come to me and they say they're undecided, I've actually pulled it up and said, well, you know what? Look at what you chose. It looks like you chose all the things that say you'd really like to be in control of your treatment schedule. Those are all things that relate to being on a home therapy. And so it allows them, you to guide them and help them make a decision because, this is my personal experience, but in the past when I would get the patient who was undecided, I'd be like, well, they don't have to decide today. You just put it off and put it off. And so it gives me somewhat of an action step or a way to be able to go through and help guide them with whatever it is and what matters to them. So once they go through this and they make a choice, if they make a choice, then the treatment preference is broadcast throughout the EHR. So once the patient's enrolled in a program, there's an alert banner in Epic. So when you log into the chart, there's a banner that says that the patient's enrolled in the program, and they direct you to the problem list to where their kidney failure treatment preferences are. And we built these problem list codes or diagnoses codes. They all map back to a CKD, ICD-9 or ICD-10, so an unspecified stage for CKD, but they have unique codes, unique IDs, so that we can actually track those through on the back end. And ultimately looking at outcomes, we can see who's chosen what modality, and if they change their mind, anytime the problem list is changed, that's stored. So we can see if they started out as being undecided and then they changed their mind to hemo, and I've had many patients actually, there's a lot of changing depending on, other factors in their life. So, they're kind of long, I will say, but there was a lot of back and forth with now I'm blanking on the team. It's not the Epic team, but whoever's in charge of these diagnoses codes, actually they cared very much about what the terminology was, the IMO codes. So we went back and forth about making sure that the patient was there so that everybody knew that it was the patient's choice, not the provider's choice, and all the modalities were there. So, but it's really nice to see it on the problem list, and they link back to a chronic condition. For those of you who have Epic or EHR, they're at the top, so that they're right there for everybody to see. In terms of psychosocial support, we are partnering with the NKF. I know there's at least one person from the NKF here with this peer support program. Right now it's a telephonic peer support where patients can be hooked up with other patients who are on a given modality. So if you're thinking about doing chemo or transplant, they'll pair you up with someone who's on that modality, and they can talk through with you about what their life is like on that particular modality. I think this is helpful for that aspect of denial, where if patients are sort of not really ready, they don't feel like it's really a problem, they don't want to think about it, it just seems scary, then talking with someone who's been there. I mean, I can talk till I'm blue in the face, but I don't have kidney failure, and there's just no way around, I can't change that. And so talking with someone who's really been there is really helpful, and has been really helpful to the patients. And then we have a behavioral medicine program, which is a psychology program, that all patients in our program get referred to at least one evaluation. And I want you to think about this similar to how many comprehensive oncology clinics work, or even transplant, where you come in and you meet with the surgeon, and you meet with a medical oncologist, and you meet with social work, and then psychology. It's just part of the package. That's how we view this too, because patients facing kidney failure feel very much the same way. It's a life-changing decision. And so we have all our patients meet once with behavioral medicine. It's either in person or through telemedicine. And it's a comprehensive assessment that it's not just about, because we get a lot of misconceptions about this, it's not about diagnosing you necessarily with depression or anxiety. It's really about screening you for all the things that could be important in your decision making. So mental health disorders is just one of those things. And if you do have that, then they could refer you appropriately to psychiatry. But more also assessing your coping strategies. Do you have a coping strategy? Is it a good one, or is it one that's maladaptive? Do you have enough social support, or are you doing this all alone? Do you have any barriers to adherence, etc.? And I'd like to emphasize that it's really about connecting them with someone in a way that's non-stigmatizing, so that they don't feel like you're just making me go. It's not just you, it's everyone, actually. And even if you're not having any problems now, what if later, when you actually do end up on dialysis, you are struggling? You will have met, Charlotte, who you can go back and talk to and feel like you already had a connection with. So I love that aspect of the program. Here's the tracking tool. This may or may not be helpful to some people, but this is what the case managers use in their individual note that they can go through. So if someone wants hemo, they make sure that they've gotten a referral to vascular. Did they get to go to their appointment? Did they follow through with their appointment? And did they get their fistula for each of the different components? So like the registry is more of the population management tool, where they can look at the whole population and see who do I need to be enrolling. The tracking tool is on the individual level. Can I make sure that the patient's completing all the steps that they need to, that everybody's getting the same care? Okay, so that's a summary of the Prepare Now, or Kidney Transitions Care Infrastructure and Program. What I wanted to talk a little bit now was just different forms of patient engagement and research and discovery, and then it's usually the questions that I get, and given this is Patients as Partners conference, that may be helpful to others and how we've done this with our patients. So there's lots of ways to get engaged in research or discovery. Donor, and here's just a listing. You could be a donor, so you could be someone who funds research and just donate money, but you don't actually participate in it at all. You could be a volunteer, and I don't mean a research subject volunteer. I mean you just volunteer your time to help support research, sort of like similar to a hospital volunteer. You could be an advisor, so a patient who sits on an advisory panel or an advisory board, like a patient and family advisory council. You could be a passive or limited research participant, so someone who I might do a survey, but I really don't want to come in and have any, I don't want my blood drawn, I don't want to take a medicine, I don't want to be involved in any of that stuff. Or you could be someone who really is actively, is a more active research participant who comes in for different research visits and gets their blood drawn every time and gets multiple surveys. And so it's just one is not more important than the other. They're just different ways of participating. At Geisinger, we have this MyCode initiative. That's a genetic study, actually. But patients, every time they get their blood drawn, they just take an extra tube, and they get their blood goes into the MyCode project. And so a lot of people like that because it doesn't really involve anything. They're already getting their blood drawn, so it's just an extra tube. They're not having to get stuck again. And then there's the co-investigator, a co-investigator for research, which is what the patients did in this project. And finally, an overseer. An overseer is someone who is involved in sort of more research oversight. So you could even sit on an IRB, or you could be on an ethics committee. That would be an overseer. So I'm just gonna talk about the ways that our patients have contributed to this project as co-investigators. They even get, so it's co-investigators, you actually get paid to participate in research, just like anyone else who's a study team member. So in our study, we identified patients through the American Association of Kidney Patients, and then also our health system and the nephrology department nominated patients or recruited patients who were interested in serving as a co-investigator on a study. So we have 8 patients and family co-investigators. And even from the very beginning, and this is, very much, this is what PCORI expects, but our patients have been involved in all phases of the research project, even from the design and conception phase. So even before we submitted a PCORI project, they were involved. And in fact, it was the patients on this, we had a series of focus groups with patients across the country, the 8 patient and family co-investigators, to get their input. And it started out as just this, pragmatic study looking at the decision aid, which was just that booklet about decision making and about dialysis treatment choices. And then it grew and grew, and then it became apparent that, hey, you know what, we actually should be applying to PCORI for this, because the patients helped change and design the whole program and what they thought would be helpful and all the steps along the way. So even before we did that, they helped us design it, they helped choose the outcomes, they helped write the proposal, so they even went through versions of the draft for the PCORI proposal. All those meetings that we had were also transcribed. We went through and we looked at themes. What outcomes are the patients saying are really important to them? And that helped us then, as we wrote the proposal, to say, and I'm sort of preaching to the choir here that you all believe in this type of work, but there are many venues that I present at where people are sort of like, empowerment, really? And so it's great that I can say, you know what, this is what matters to our patients. This is what's going to make a difference in their lives. This is what they want. They don't necessarily care about hospitalizations or mortality. That's something that, researchers may care about. But they could have come back and said, you know what, I don't want to be in the hospital, and that would have been fine too. But the whole idea is that the whole point of the clinical research that I do is to help patients. And so this is all of the stuff that we wrote, and all the entire project was based on what patients thought was important. So we had 5 major study design revisions. We kept going back and back and back. So it was a big deal. And as I said before, it started out as just this simple education program, and it turned into this comprehensive health system intervention, which has these provider tools, educational components, behavioral components, psychosocial support for patients to improve their care. And these are the outcomes these are what they said were the most important. So this control and empowerment. Grief was a big one. Kidney disease knowledge. They want to know more and earlier. They felt that it was too late. Like by the time they had kidney failure, everybody said, I wish someone had told me sooner. Or even if I was, and everybody acknowledged, you know what, yes, fear and denial, and it's all relevant, but if someone had just said, you might be at risk, just said it once, that I knew that it wasn't the first time when I ended up on dialysis, that wasn't the first time someone said it to me. Anxiety, depression, and then acceptance. So these are what they said were the most important. Aspects of the project specific aspects of the project that patients have been involved in. So as I said, they're paid, just like any other team member. We meet at least monthly with all of the team members, with a full team meeting all the investigators from both patients and the medical researchers at least once. The patients also have their own stakeholder group, where they have monthly meetings together, just the patient and family co-investigators, to address issues that are very specific or relevant to them as patient stakeholders. If there are things that we want to just bring back to them that would be really helpful to get feedback on, to spend an hour going through, like just recently we revised our screening and recruitment materials because we were getting a less than anticipated response rate on our surveys. And so we were able to go back to them and say, hey, can you guys look at this? Here's the letter we're sending out to the patients, which they actually did help us write the first time around. But we could go back to them and say, say, hey, look at this again. What do you think? Can you guys go through and see if there's any way we could make this a little more patient-friendly? Is there something that might be deterring patients? What could we do? And same with our telephone survey. We had them go through it, and they got to practice doing this survey before we ever did it. They went through it to see how long it would take. They helped us choose our study logo. They helped us design our brochure for our study brochure. So it's just been really great. And it's amazing how many times when you're on a work group, there's a patient that they volunteered for different work groups. There's probably 9 work groups that we have that meet monthly, and they all volunteered to sit on different work groups. And so even in like a data meeting, you would think that may not be something that they would be interested in, but in fact, so often we'll be going back and forth about numbers, and then we'll sort of be like, well, even if it's a question, maybe we should get rid of that. We can ask them, and they chime in and say, it's always really useful information. I said about the communications materials. A lot of them have participated in blogs, online, and gotten to do interviews and things. And so I think it's been really great for all of them to be involved in this type of research and attending the annual PCORI meeting. They've gone to a bunch of other meetings too that we've had. The ASN or National Kidney Foundation meetings. We've had posters at those, and they can come and help present the posters in that academic forum. And then mostly they ultimately, the goal is that they ensure that all aspects of our intervention respond to patient and family members' needs. So when we're saying something that really is not very helpful and we're debating about it, that's ultimately not going to be useful to the patients, they'll say, hey, you know what? We'll be like, we're arguing back and forth. And we'll say, you know what? Let's ask Brian. And then Brian would say, well, actually what I think is this. So, and here's some of our team members. So there's eight patient and family co-investigators. Brian Bankus is one of our Geisinger patients. Shakur from Jacksonville, and Patty Danielson from Oregon. Katina Lang-Lindsay, she's from Alabama. And they all have different things to say. They've all done different things, home hemo or transplant or PD. Some of the family members, like Suzanne from North Carolina, she has a long history in her family of polycystic kidney disease. Lana Schmidt from Illinois, Amy Schwaboda, and then in Maryland, and then Peter Woods from New York. So they've all been great. They've all been participating and contributing so much to the project. So I just wanted to highlight them because these are quotes from them. And this is the team. It's a big one. It definitely takes a village to accomplish something like this. We had a lot of infrastructure at Geisinger to start with in order to develop this project. The Center for Clinical Innovation and the Institute for Advanced Application built all the technical tools, and so that was a role that I had been involved with prior to this project. So I already had a team in place that could build a lot of those things. But yeah, so Duke, Geisinger, Hopkins, University of South Carolina, there's our patient co-Is, and then there's the stakeholder partners. So the NKF, the AAKP, the RPA, the Mid-Atlantic Renal Coalition, the Council of Nephrology Social Workers, and the Medical Education Institute. So it's a big group, but I feel like it's all just come together to create something that's really powerful. So we're looking forward we just started rolling out the intervention this summer. So July, August, September, October. By the end of October, we'll be at all of our 4 intervention clinics. Things are going well, and we'll see how things go.